Good afternoon, everyone. My name is Joey Cody. I'm pursuing a master's in counseling at the Chicago School. And we have presenting for us Amanda Brown and Shuhan Su. And the name of their presentation is Providing Trauma-Informed Clinical Supervision in Training Mental Health Professionals. So make sure you're in the right session for this afternoon. And we'll try to save some time at the end for questions. And we'll be also putting some information for continuing education credits in the chat box. So keep an eye on that too. So I'm going to turn it over to Amanda. Please make her feel welcome.
Hi, everybody. Shuhan will be joining me soon. My name is Amanda. I am going to actually just go to the next slide here so you can see if I can get it to work. Hold on just a second. There we go. Can y'all all see my presentation? Just want to check. Okay, I just want to make sure because I know sometimes I think I'm screen sharing and people are like, I can't see. So thought I would check that early. So my name is Amanda. I am a mental health counselor. I work at the U.S. Department of Veterans Affairs, where I direct a training program for mental health clinicians there. And I also work in their outpatient mental health clinic, and I'm a doctoral student for counselor education supervision at National Louis University. And then my co-presenter, I'll just kind of briefly introduce her since she's not here yet. She said she's running a little late. Is Shuhan Su, and she is also in my program with me. She works in the inpatient and outpatient setting. She does DBT, CBT. She runs the supervision program at the hospital she works at, and she specializes in trauma there. And she's also a doctoral student. So just a brief introduction about us before we get started. Okay. All right. So for today's agenda, I just want to give you a brief overview of what we're planning on doing in this session. For the first part, we're going to go over, what trauma is, the definitions of trauma, what types of trauma there, essentially what is trauma, what types of trauma there are, the impact of trauma, and then trauma, and specifically, we're going to focus on the impact of trauma in mental health professions. So we get just a general overview of trauma within the general population, and then trauma and mental health professionals. And then from there, we're going to kind of transition into trauma-informed supervision, which is why we had this session. So we can talk about, what trauma-informed supervision is, some of the basic principles of it, some uses for trauma-informed supervision, and then of course, some time for questions and comments. So that's just giving you a brief overview of what we are planning on discussing today. All right. So first off, I want to kind of start off with just giving you a little question. So what comes to mind? Anybody can just shout this out if you want to, or if you want to type it, when you think of trauma. Real quick. All right, so I see some things in the chat box. Sharp violent pain affects every lifespan, adverse childhood experiences. Yeah, those are all good ones. Body keeps the score. I like that one. Yeah, horrific experiences. Yeah. Exposure to something disturbing or life-threatening. Yeah, good thoughts. Yeah, and the reason I asked that kind of as a question is life-altering. I like that. Just so it's things that change, all of your thoughts and experiences within that. And of course, I know I'm speaking to probably a group of people, I'm assuming in this presentation, that are either mental health professionals or studying to be mental health professionals. So but the population, y'all are a little more familiar than the general population with trauma based on what we do. But the reason I ask that is kind of because when we think of trauma, really, there's no real, one of the things that's interesting is if you research trauma, there's actually not one universally accepted definition of trauma, right? We have our ideas, like some people said, life-altering experiences, adverse childhood experiences, something life-altering or traumatic. all kinds of things. These are all good answers. They're not wrong. And there's actually not one universally accepted definition of trauma, right? So what really is trauma? And again, I always open this presentation with this, because if you guys, any of y'all have checked on like TikTok or, social media or read recently, it's a hot topic, right? Everybody's talking about trauma. And I'm not saying that because it's a bad thing that people are talking about trauma. I'm just kind of pointing out it is, and so you're going to hear different experiences and thoughts and ideas when it comes to what trauma is. So according to the Merriam-Webster dictionary, it means wound. So basically it is the word for, if you've been physically or emotionally wounded, it means wound, which is interesting. That's where the word comes from in the Greek. It means wound. The APA, of course, which I think is a decent definition because it's maybe the American Psychological Association, says that it's any disturbing experiences that results in significant fear, helplessness, disassociation, confusion, or other disruptive feelings intense enough to have a long-lasting negative effect on a person's attitude, behavior, and other aspects of functioning. So that isn't a bad definition. It goes along with a lot of things y'all were already typing in the chat box, such as, it's significant fear, it has helplessness, there's some disassociation involved, maybe confusion, and it really comes and it changes a person's attitude of behavior long enough to have some changes in functioning. SAMHSA says that, it basically refers to experiences that cause intense physical or psychological stress to some kind of reaction there. And it results from an event, series of events or circumstances that is experienced by an individual that are physically, emotionally harmful or threatening, that has long-term adverse effects. So that's SAMHSA's, and it's individuals functioning, physical, social, emotional, or spiritual well-being. And then one of you, I know, mentioned adverse childhood experiences. That is not a definition, but we do know that a person's childhood or experiences that are adverse in their childhood can be even more significantly impairing. Of course, any traumatic experience at any age is going to be, but specifically some of those adverse childhood experiences that people have can make a lasting impact. So all of those are parts of what make up trauma, and what we as professionals and clinicians view as a traumatic experience. So again, there's no universally accepted definition of it, but these are good ways for you to think in frameworks of what is it? What is trauma really? Because you're going to hear a lot of things out there because it is being talked about, and that's a good thing in that it's being talked about. And it can be a not good thing in that sometimes information is not accurate or correct. So just giving you those thoughts about that. What is the impact of trauma? So traumatic events, as you guys kind of talked about, are neurological, they're biological, they're psychological, and social. So they affect our whole body, and they can have different impacts on us in many different ways. We now know that it's not just a psychological issue. It's not just a social issue. It actually affects our neurology and our biology when we have exposure to trauma. And it's going to be different for each person, but we now know that it is very real. It does affect the brain and your neurobiology and all that. So that's some of the research that we've been learning about trauma has really opened up a lot more into how trauma affects us beyond just the psychological effect. So, your neurobiology in your brain, we're not going to get too much into the weeds with that in 1 hour presentation, but your neurobiology and brain chemistry changes. And it can, sometimes people that have trauma, we know now, we've done a lot of research, they have earlier deaths. They are more likely to die by suicide, and even other things too, even like physical issues or having issues like cancer. They are more likely to have issues with physical health problems as well. Going along with the body keeps the score, which someone mentioned, where it does impact your whole body. So you can actually be more likely to be physically sick if you've had a significant trauma history. Somatic symptoms. So people often have those psychosomatic issues that happen with trauma. They might have some social, emotional, or cognitive impairments in their life. Sometimes they adopt unhealthy behaviors. You see people that when you work with people that have trauma, which any mental health professional, I would argue that every mental health professional who's worked with mental health has experienced a client with trauma. I don't think you can avoid it no matter what area you work in. It's impossible. So essentially, you might have people that have increased eating disorders. They're going to have substance abuse issues, more likely to be self-harm, more likely to have sexual promiscuity issues that can be harmful, and violent behaviors. This doesn't mean, of course, that everyone who has trauma is going to have any of these, but these are things that if you have trauma, you are more likely to see, which is why I would argue that every mental health clinician has seen people in their life that have trauma. And you're going to have severe and persistent mental health disorders, which again goes along with just what I was saying. They're more likely to have depression. They're more likely to develop PTSD, anxiety disorders, or personality disorders just by the fact that they have a trauma history. Research again found that there's a huge correlation and connection to dysfunctions if you are in adulthood, if you have a strong adverse childhood experiences. So people that have a lot more adverse childhood experiences are far more likely to have more adverse experiences as an adult and have more issues. So, we know that obviously trauma at any age is going to affect you, but if it is as a child, it seems to set you up during those developmental years for a possibility that it's going to be more harmful. So that just gives you a little idea of how trauma can impact or has the potential to impact anyone. All right, so there are some, quickly, I'm going to go over the 4 F's of trauma, we call them. Those are the ones that you see them all over. They're pretty popularly talked about, but people have responses, right? So some people tend to fight, where they get angry when they have trauma. They are controlling. They tend to be a little narcissistic, maybe are a bully. Other people have that they're workaholics, so they avoid their trauma by overthinking, working. I see a lot of mental health professionals that are in the flight where they think they can overwork themselves and help other people by avoiding, which, seems like a good idea at the time. That tends to be what I have experienced. They have anxiety. They might, be a little bit perfectionist. You have the freeze people that they get stuck. Again, I see some mental health professionals in this one as well. They kind of disassociate, they might isolate, be a little numb to their feelings. And then you have the fawn, which is those people pleasers, no boundaries, they're overwhelmed, there's your codependent friend. So those are the 4 common responses to trauma that we now see. And each person is going to be a little different, and they may have a combination of these. They may exhibit more one of them. I think most people that I've experienced tend to be stronger in one. And in mental health professionals, since we're focusing on the supervision of them in this profession, I have seen more, and I would like to do more research on this. More flight or freeze tend to be the ones I see, especially flight, because they want to work and save the world. And so they tend to be stuck into that, but by avoiding. I don't see as many mental health professionals that are fighters. It happens sometimes, but it's not as common. So those are different reactions we can often exhibit when we have trauma, especially a significant trauma history.
Hi, Amanda.
Hey, you're here?
Hi, everyone. I'm one of the presenter. Sorry for joining a bit late because I'm actually in the process of stepping someone up. Sorry about that, but I'm glad that I can join, and thank you for Amanda for trying to take care of the session. Thank you.
I already introduced you, but happy to see you here, Shuhan. I'll just finish up the slide I was doing, and then
Sure.
we'll let you go ahead. But I introduced you briefly for you.
Thank you.
Types of trauma we see in mental health professionals. So we see different ones. I'm going to focus again. These when I say in mental health professionals, these traumas can be experienced by people outside of the mental health profession, but I'm only focusing on it in that for this talk. So we see mental health professionals, like I said, who have past trauma. We'd be lying if we said we don't have past trauma as mental health professionals. There's a lot of us that do, and it is a thing. So, you're going to see people that come into a program and, because they have their own past trauma. Many of us do. That's not a bad thing. I want to put that caveat. It's not a bad thing. A lot of times we are wounded healers. A lot of people want to go into the mental health field because they want to help people because they've experienced some, and that doesn't have to be a bad thing. It only becomes a bad thing when they're not dealing with it and they're not processing through it, is what I would say. But it's not a bad thing in and of itself. at all, because I think that can really encourage people to heal and encourage people to want others to heal. So we do see that though, but it is a reality that people come in with past trauma. We see direct trauma, which again is mental health professionals that experience trauma directly. And that can be, inside or outside the workplace. I had one supervisee who got attacked by a client. That was a direct trauma. That was not indirect while she was working in the field. So you will see that, or they might have, I had one who had some abuse happening with a spouse that was not in the workplace, but it was still happening while she was a mental health professional. So that was, again, a direct trauma during her work as a professional. You have re-traumatization. So that happens when, you might have someone who has a history of something, and maybe a client, this is very common. And we talk a lot about that in counselor education programs or training programs for mental health professionals. They might be re-traumatized because it's something that triggered them. When we see clients, we get into the weeds with them. And so sometimes they're going to re-traumatize an experience because it reminds us of something we went through. One of my supervisees came up to me and she was like, I'm having a hard time with this client because some of his issues remind me of my relationship with my dad. And it was kind of re-traumatizing her hearing him talk about his relationship with his daughter in session. And so that can kind of be that way of hearing things that are similar to our story, which is hard as a clinician, where we have to balance how do we deal with that. So that's something that happens a lot with professionals, that because we hear so many stories and because we also come with our own baggage and our own background, we have to be careful how we deal with that. Vicarious traumatization. This is the one I want to spend a little more time focusing on because this one is more specific to people in the health profession. It doesn't have to be mental health professionals, but mental health professionals are definitely definitely on the higher list of types of professions that get it. It also is quite common in like police officers or fire workers or sometimes teachers or social workers that work more in like case management. That definitely can happen as well. But any of us in the mental health profession, whether we're psychologists or psychiatrists or social workers or counselors, can definitely experience vicarious traumatization, which basically means that we are repeatedly exposed to clients who have trauma, right? So all of a sudden we see a dramatic shift in our worldview because we are repeatedly exposed to it. If you are, for example, a clinician who works with abused children, which I've done some over the years, you're going to be exposed to abused children over and over and over and over. So how you would see vicarious traumatization happen in this clinician would be all of a sudden they think it's not worth having children. All children are terrible. All parents are terrible. There's no such thing as children that are healthy. All children are bad. All parents are bad, because they start seeing so many that they put it into this general worldview, and it changes the way they see the world. So their general outlook is different when they have it. And it happens usually through exposure repeatedly to the same thing, where, a clinician who works with couples starts believing there's no such thing as a healthy relationship because they work with couples that have huge issues all the time. So we see that vicarious, and really the difference between secondary stress and vicarious traumatization, because they're both used, is that in vicarious traumatization, you start seeing it's usually from repeated exposure to similar traumatization that is maybe not the trauma you had, but it's the same over and over again a lot of times until you start changing the way you view the world from this. Secondary traumatic stress syndrome is where they experience PTSD-like symptoms from experiencing traumatic events that may not be, this is not their direct trauma, but it's stress connected. It may not even be like, it's not even necessarily re-traumatization because it's not similar to their story, or oftentimes it's just from helping other people all the time. So it's more like all of a sudden you're listening to someone's traumatic story and it affects you, and you start developing some of these PTSD symptoms, and you start thinking, wait, I don't have PTSD because I wasn't the one who was raped. But they start connecting with that client's story so much that they start developing these symptoms. And obviously the reason why mental health professionals are so likely to develop this is because we hold space for people's deepest, darkest experiences, which are sometimes hard to listen to. And so we are at high risk to having either vicarious traumatization or secondary traumatic stress. So, you know, in secondary traumatic stress, you're developing PTSD-like symptoms, but you're not necessarily changing your entire worldview as you would more in vicarious traumatization. And both are very likely to happen. And I do want to make us aware of that, because when we're supervising, if we are learning to be supervisors, looking and being aware of these types of possibilities that are highly likely in mental health professionals, is something to be aware of as we realize that, you know, we need to protect ourselves and protect our supervisees as well. So those are just some of the ways that mental health professionals can potentially experience traumatic experiences in their work life. And the last two specifically are really unique to the helping profession. All right. I'm gonna let Siobhan take this one.
Thank you, Amanda. Yeah, so I think it's important as supervisor that we understand how to incorporate the trauma-informed care into our supervision process. And if you could just reflect briefly about what your experiences are in the past with a supervisor or supervisors, you know, what was good about it or what was not so healthy about it, and think about, you know, there might be some more difficult supervisors, or the experience was difficult because the supervisor was judgmental or had implicit bias, or was not transparent, was not understanding the stress or situations we were in, and also reflect, you know, how we can help as a supervisor in this process. So, you know, there were a couple of researches about the trauma-informed supervision. So it says like counselors are at risk at experiencing burnout, vicarious trauma, and secondary traumatic stress, which can lead to impairment, and which is also in part of the ethical codes for the impairment piece. Is if we don't incorporate this, and you know, that may not be a very ethical a supervision process, right? Because we may cause harm to the supervisees and indirectly also causing harm to the client, because supervision is a parallel process to counseling. So another research is talking about this provide space for supervisees to process their concern and grow with a trauma-informed supervisor. And then counselors deal with trauma in their client's life and sometimes in their own lives. This approach provides training and skills to help them navigate trauma in themselves and their clients. So again, it's not only important to be aware of our own trauma and the supervisees, clients, like how that interplay in this didactic process, and as well, and how to use supervision and process transference, counter-transference, using consultation if you struggle with this process, with, you know, when supervising the supervisees. Okay. Also, in a nutshell, I think, you know, trauma-informed supervision is an approach that recognize and address the impact of trauma on both the client and supervisees within a professional setting. So it provides integrating trauma knowledge, principles, and practice into the supervisory relationship and processes. So sometimes supervisees could get triggered, like what Amanda was saying, you know, and during the session, and how to deal with that. Also, how can we help supervisee to kind of recover from that? Or maybe we will recommend trauma therapy for the supervisee to deal with their own trauma. So that's part of the supervision process, is to be more aware and also guide our supervisees. And then it's approach based on the knowledge of the impact of trauma, and to aim to promote resilience of the supervisees and the clients who got impacted by trauma. So I think it's straightforward, but it's actually not very easy to do it in practice, because, you know, it involves a lot of self-awareness, self-reflection. A lot of times we may not mean certain things, or the supervisor may not mean to deliver a certain message, but then it came across as you know, very traumatizing, or the supervision process could be traumatizing as well. So again, it's not easy to incorporate, but this is very important for us to be aware of. Yeah.
All right, thank you. So kind of going along with what Shuhan was saying, these are like, I feel like a lot of things in life, it sounds great when you talk about it, and then when you're actually trying to practice it, it gets a lot more complicated. So that's kind of where we're going to break it down, realizing that that's just how a lot of things in life sound. So I'm going to go over some practical principles now, whereas, she kind of went over like, what is trauma-informed supervision in a little nutshell, and then go over some of the 6 principles that are often incorporated into a trauma-informed approach to supervision. So that those of you that may be supervisors or thinking about supervisors, or if you're a student and you're going to have a supervisor, this just gives you a lens for how this might be incorporated in a supervisory relationship for mental health professionals, because every mental health profession has to have some level of supervision, right? Which is a good thing. You get supervision during your internship and practicum if you're a student, and then to get your licensure if you're a counselor. Same thing for psychologists and social workers and marriage and family therapists. We all have a supervisory process to obtain that license where you're going to have a clinical supervisor. And you'll find supervisors that go from all different approaches, but this one helps look at the lens of, wait a minute, if I'm going to have, how do I as a supervisor have a trauma-informed approach with my supervision to my trainees? So the trauma-informed approach has 6 different general principles that we're going to use for this particular presentation. So again, you see this diagram where you have the supervisor and the supervisee in the center. That they have a relationship with each other, obviously, of some sort, because they're a supervisor and supervisee. And for many times, that supervisor in a mental health profession, they might be supervising them for, up to 2 even longer years clinically. Because that clinical supervision piece takes a while, which is a good thing. We have a lot of gatekeeping in our profession, which I think is not a bad thing. So you're going to have quite a relationship, because this person, you as a supervisor, you're developing these future professionals, and whether they want to or not, that supervisor will have a huge impact, because you're meeting with them to help develop into a professional. And so it is a very special, I think, relationship. And one that I know for me, I can think of all the supervisors I've had. I had several, and how much I learned from them, and some I wanted to emulate and some I did not, honestly, as far as the way they did supervision. But we like this one because of the way it's easy to incorporate, as far as you can put it into a lot of different models and a lot of different spaces. So the 6 different areas are, there's trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, cultural, historic, and gender issues, and safety. And I'm going to go over each one. We are going to go over each one of these. So I'm not going to spend more time on them, but those are the 6 different principles that we are going to use for how to have a trauma-informed supervision approach. All right, so I'm going to start with number 1. It's safety. So safety, I think, is just so important in general to anyone. I mean, if you think about it, if you come from a place of having traumatic experiences, and you can have traumatic experiences, as we said earlier, that you don't have to develop PTSD to have a traumatic experience. You may, but traumatic experiences may or may not lead to PTSD. And so one of the first things you want to look at is safety. Think about it. If you have trauma and you come, what makes you feel like you start to heal from your trauma? A lot of times when you feel safe, you start to feel like, wait, I can be myself a little bit because I feel safe here. This feels different than that unsafe feeling of trauma, right? And so as a supervisor, promoting safety can really help develop supervisees. It's basically, and I want to say it's not just mentally, because we as mental health professionals, obviously we focus a lot on that mental piece of it, but it's also physically. And what I mean by this is like, as a supervisor, you're a little bit of a gatekeeper and a trainer, because you've been down the road a little longer than your supervisee, and you're kind of there to help them grow and learn. And part of that is promoting that safety. So I know one example I have is when I was a newer clinician, I worked for an agency. They wanted to put me in this space. They had never had a counselor, and they're like, oh, she can just do this little room off the waiting area. And the waiting room, this little room, it literally, you could hear everything I said. I mean, if I was talking like I am now, I wasn't screaming. You could hear every word that was said in the waiting room, even with a sound machine. And of course, I'm like, this feels very unsafe, right? I'm sitting here doing therapy, and everyone in the waiting room in a small community can hear what I'm saying. So I complained to my supervisor, and he did protect me, as a supervisor should, and said, she's not going to work there until you fix this. And he, in his snarky sense of personality, said, he was a psychiatrist, had a very funny sense of humor, and said, this is basically like her work, a gynecologist doing their exams with a huge window to the waiting room, having a counselor do their sessions where everyone can hear, because in counseling, they're sharing all these very personal, intimate details, right? And so he's like, this is completely inappropriate and unsafe. And so I was glad that he protected me and basically was like, they're going to pay you and you're not going to work till they fix that problem. You know, but in that case, he was right. It was an unsafe environment to do counseling because there were so many ethical issues. And I will say that's a physical safety issue, right? That's saying, look, this is not a physical environment you can do your job. You know, when you're the new person, you're a supervisee, you're not going to get usually the big, you know, corner office with the big window, but you do have to have a place that is physically safe for you to work. And I do think supervisors do need to work to ensure that, just because even from a trauma approach, it's not fair if they're putting you in a place where you are not safe. You know, having a supervisee work by themselves late at night, I've seen that happen. I'm like, this is so not okay. You know, being like, oh, just call me if you need anything. And the supervisor leaves them by themselves in the private practice. There's something that does not feel safe about that. Especially, you know, it's just, there's someone else that needs to be there. And that's the supervisor's responsibility as the gatekeeper. So that's physical safety, right? So fostering that environment, and also, you know, encouraging them to practice their counseling in a safe way. So you're modeling that for them, but you're also encouraging that for them. So, you know, noticing what feels safe. One of the things they talk about in the environment is, you know, don't put yourself like way in the back of the office with a big desk in front and your client is by the window. It's not a safe way to practice. You know, and so just general safety ways to look and be aware that you should model as a supervisor, but you can also help your supervisee learn to be aware of that. So, but then there's also the mental safety piece, which we don't want to forget. So it's just promoting healthy boundaries mentally. You know, sometimes as newer clinicians, they don't have good boundaries because they're developing them. And especially if they have a trauma history, they may not have great boundaries with their clients. It can be a very tricky thing to navigate when you're a new clinician. Like, these people feel like my friend, they're coming in, or, you know, my supervisor feels like my best friend. How do I keep those boundaries? You know, how do I not overshare when I connect with them so well? And so how to have those, and one of the ways that I think modeling can be a very powerful way to do it. So, because you're going to have a dual relationship with your supervisee, right? You know, I mean, I think there's nothing, we want to run away from dual relationships, but the truth is they are there. And so I think it's not getting rid of them as much as promoting how to ethically have them. You might be your supervisor's administrative and clinical supervisor. You might be their professor in a class and their clinical supervisor. It's not wrong necessarily, but it's how to do it appropriately and ethically, and make sure that you're taking care of yourself as a supervisor. You know, and one of the things I think that really this is one of the best pieces of this is that a good supervisor, a safe supervisor with this informed approach, is predictable and consistent. You know, if you think about yourself, if you have trauma or traumatic experiences, nothing makes you feel safer than predictability and consistency with someone, where you're like, I don't walk around thinking, I don't know what my supervisor's going to say. I'm not sure how they're going to react. They might be late. They're not someone I can rely on. They're not someone I can, you know, trust to do what they say. And that safety issue gets broken down. So a supervisor should strive, we're all human, of course, but to be someone who is consistent, someone who has clear expectations, someone who reacts in a way that their supervisee can have expectations about them. And that is a good thing, because it promotes that connection and that feeling of safety. And when people feel safe, they start to thrive. And then using, again, just non-shaming, non-blaming, and non-violent language in the way you communicate.
Thank you, Amanda. I think the safety is so important in the supervision process, and hand in hand with the second principle, which is the trustworthiness and transparency, because you kind of need to build that trust. It's very similar to the therapeutic relationship with the clients. You know, there was research indicated that if you have a good rapport with the clients, you tend to have better therapeutic outcome. And so similarly, you know, having that safety space, you can also build on top of that is the trust and the transparency, because that's also part of the being able to be consistent and predictable. And so again, transparent is very important in terms of the process of supervision and the decisions. kind of set the expectation like what Amanda was saying. And then sometimes, supervisors don't know everything, it's a good modeling for the supervisors to even say, hey, you know what, I'm not sure about the answer, but I'll find out. Like, especially some legal issues or different new protocols or different things, we need to make sure we are checking with the agency and our legal department. So again, those are very important modeling behaviors that supervisors can demonstrate. Also, we need to learn how to trust or, build that trust with a supervisee. Not to say trust everything they said, but even like trying to help them to understand confidentialities, and how this information may not be used against them. Like, even though we are gatekeeping, but there are things that we can also help them to grow, even though we also need to gatekeep. So I think it's a kind of a dilemma, right? We want them to be honest, but at the same time, it can also damage the relationship. But I think if a supervisee is honest or the supervisor is honest, hey, I'm not sure about this, or I didn't know how to respond. And sometimes supervisee will be like, yeah, I didn't know, or we can give them assignment or homework to work on it so that they can feel better about themselves. So these are some of the things that we can kind of bring into the supervision process. Definitely clear expectations, and then collect feedback, because we don't want to have one-way supervision that we keep talking and coaching and teaching, but we are not sure, if the supervisee is thinking or feeling or just kind of being, accommodating, but not really able to follow and not able to ask questions. So again, I think that's an important part. Not overpromise, meaning we want to help, but we cannot promise or over commitment. And then aware of the transference and counter transference, as we talked about before. And then we also, I mentioned that already, but we want to seek, encourage supervisees to seek trauma therapy or therapy if needed. The next one, principle 3. The peer support. And the peer support piece is also very important in the trauma-informed supervision process, because they cannot, it's better to have some other support besides supervisors. So like, remember when we were used to be interns or new clinicians, we kind of have those support from our peers, if we are learning, and then kind of process through. So I not only individual supervision, but I think group supervision is also very important for them to, and I think that's required by KCRAF to have both during internship and predicon. This way, it can also help them to understand and then feeling more supported with people go through the same struggles, and they can also help each other to develop. They can get validations from each other that their experience and feelings and the anxiety of being a new clinicians and students, new counselors, that can be supported. And then, model the peer support for supervising to include self-care and good connection too. When they have questions, they know who to reach out to, and provide a team-oriented culture at work. So I still have contact with my cohort. I don't know any of you, but I do think like, and Amanda and I are in the same doctoral program. So we reach out to each other when we need support, because doctoral program is not easy to get through, and a lot of stress, as you know. So again, I think this is so important to have that peer support in addition to the supervision process.
Yeah, thank you. Definitely. Peer support, I don't think can be underestimated, especially when you're learning something that is hard. So, collaboration and mutuality is principle 4. So I think this goes along with peer support very well, this concept. But, basically one of the things about a trauma-informed supervision approach is it is not, as we've talked about before in some of the other principles, it is not something that where it's the supervisor is the expert and the supervisee is always learning. Of course, the supervisor should have more knowledge and experience just based on who they are, and that's why they're a supervisor. But they don't want to come across it about, saying that I know everything. They're not the culture of I know this because this. I think if I think about my own self, and probably some of you can relate to supervisors that I really appreciate, they were not the ones that were like, well, I know everything, and kind of dismissive of your thoughts and your process and your ideas just because you were younger and newer, that shuts you down, right? You never feel more shut down than when someone you're really excited about a new idea or concept or learning, and they're just like, well, that's great, but I think we're going to do it my way. Instead of allowing that process of learning, because when you are learning and growing, I love seeing new clinicians because they are so excited about, I'm learning about this, I want to try this, or hey, could I try that? And there's nothing more discouraging than a supervisor coming at, well, we don't do it that way here, or this, instead of maybe you don't do it that way here. Maybe the idea wasn't a good idea, but a trauma-informed supervisor would approach it more with, okay, well, let's talk about, why you have this idea, or what can you look excited about that? Let's process this. Even if the supervisee might be kind of barking up the wrong tree, because sometimes they are, it's still good to hear them out and let them feel empowered and heard. Then, well, we just don't do that here. Because, the second answer gives you that feeling of, oh, I guess I don't matter, which again, people that have been traumatized, they already struggle with feeling like they don't matter. They're not important. So that kind of shuts them down even more. And so using that, it's the way you approach it, which is say we're mutually supportive of each other. We're collaborative in nature in general, and I think one of the things that's also helpful from a trauma-informed approach is to pull away some of the things we don't like to talk about, because it helps open people up. So, being honest about the fact that, honestly, if you are a supervisor, you do have a power differential. I mean, let's just be real. Even if you try to be, I'm not that kind of supervisor. I'm your friend. I want to collaborate. There is a power differential just based on the fact that you're the one who's the supervisor. And it doesn't matter how any way you try to swing it, you have a power differential. And so I think it's just better with supervisees from this approach, just be real about it. You are more powerful. You do hold a position of power. It's not a bad thing, but it's good to be aware of that, and aware of that in your interactions with your supervisees, that if you're the supervisor, you're going to hold that position to them. And so you have to be aware of that. Holding positions of power requires a lot of responsibility. And it requires, consideration to that. That's part of that. And then just being, respectful of, you're not punishing, you're just encouraging and learning. Your standpoint as a trauma-informed supervisor is always, I'm not here to punish. I'm not here to, I am here to correct, but it's more, all right, well, let's talk about that. It allows a lot of collaborative processing. I love that collaborative processing as a supervisor, where you let a supervisee have their experience and their thoughts, and you validate the ones that you can. You can almost always find something about their process that is validating, even if they're not right. If they come with this idea like, well, hey, I really think I would like to do this with my client, and you're thinking, this is not going to be a good idea. But like, okay, well, you look really excited about that. So let's talk about this, and then sort of directing them in a collaborative manner. Maybe I can help you with some ideas. And then you're collaborating with them instead of just saying, yeah, that doesn't sound like an ethical idea. So that's helping give them a little bit of that power. So you're minimizing the power and control. You still have it because you're still kind of going to ultimately direct it, but you are minimizing it by allowing them that ability to process through issues and cases, because there's going to be some, every supervisee has them, and that's a good thing. You're also helping them feel, again, safe coming to you, because nothing breaks down a supervisor relationship than when the supervisee starts feeling like they don't have the ability to collaborate with their supervisor. They're going to stop telling you things, and then you end up in a big issue because they're not processing ethical issues because they're worried about being shut down. So that's just a way to approach things that, and sometimes as supervisors, to be honest with you, I've been a supervisor for a long time, and you have to catch yourself with this, because I easily you get kind of jaded to like, how do you not know that? Because I've been doing that for a long time. That's where I catch that power differential, be like, wait a minute, I need to come at it from where they are and not be like, what? So allowing that process, allowing, some of the thoughts and considerations in a way that doesn't dismiss. And so principle 5, kind of moving along with our 6 principles, is empowerment, choice, and voice. This is one I really like as well. It's just a way of thinking when you're supervising. So really a supervisor who gives empowerment, choice, and voice acknowledges, number one, that everybody has a story. We realize many people come from a trauma history. We started out with talking about trauma. A lot of our counselors, psychologists, psychiatrists, as mental health professionals, we're going to come with a story because we're human. Many of us will have adverse childhood experiences or adult experiences, and allowing that to be a part of it instead of, we all have it. It's a reality. And so don't minimize that that is a reality, and being aware that, yeah, all of us come with our own history, and all of us come with our own baggage to a degree. And then listening for feedback so that, when they give support and tools, being like, hey, so what do you think we should do? That's one of the things I like to ask my supervisees so what would you do in this situation? Or let's process it together. And giving them the support and tools, but letting them kind of use their voice. And then when they want to tell me something, that's a hard thing too, with that giving voice, is a supervisor that says, do you think I should do something differently? Or do you have concerns about this? You look a little frustrated or upset. So letting that supervisee have the power to even correct the supervisor in certain situations can be a powerful thing, because it gives them that voice and empowerment. And then again, I think the best common form supervisors act more of a facilitator and less of a dictator. They still hold a place of power, but allowing a lot of facilitation. I like to say, giving your supervisees as much choice as you can. What does that mean? They don't get freedom of choice in all areas. They're not going to, it's not appropriate. But, allowing as much as possible to be like, okay, let's talk about this. So, you need to see 30 people a week. That's what the agency is saying you have to do. So let's talk about how where would you like to put this? Would you like to work, long days this day? Is this better for your schedule? So you're giving them the parameters of, you got to see this many people, right? But how you do it, we're going to talk together and collaborate, because I want your input on what's best for you. Or I'd like you to lead a group, but why don't we work collaboratively? What kind of group do you think you want to lead? Are you interested in this one or maybe that? So you're still, they have to lead a group, but they're getting some input into how they want to do it. Do they want to do it virtually? Do they want to do it face-to-face? Do they want to develop it? Do they want you to give them a curriculum? And so that gives as much choice and options as you possibly can, so you're giving them tracks to run on, but you're giving them as much freedom and option as you can to run with it and use their voice to tell you. Sometimes supervisors will say, I really, can you give me more input? I don't feel like I know what I'm doing. And I'm like, okay, you told me that. I gave you that voice and you said, I want more curriculum. I can't do this. I've had other supervisors that are like, can I just do it myself? And if I feel like they're ready, I'm like, you know what? I will sit in your group and you do it, because I would like to see you do it. So that gives them a little bit of that ability, because not every supervisee is going to develop at the same level or have the same confidence. And so you're giving them voice. And I think if they feel safe if you're doing this well and they feel safe, they won't mind coming to you and admitting, I'm not comfortable. Can you help me with this? When they don't feel safe, when they don't feel empowered, when they don't feel they have a voice, is when you're going to see supervisees, supervisees be like, oh, I'm fine. When they give you the I'm fine every time, they're uncomfortable and they're scared of admitting something. So you want them to feel that freedom, and it provides choice and options. So, and then of course, just recognizing that supervisees are not one person, right? They have a lot of roles. They have a lot of space. So, all right, I'm gonna let Shuhan take this one.
Yeah, so this is our last principle. I think, in terms of the cultural, historic, and gender issues, these are very important to be aware of, because we have different backgrounds, different cultures, and it's important to recognize that, even like eye contact, the way expressing appreciation, or, some people are more passive due to culture, or they may view mental health as a shame thing or a stigma. We need to kind of help them to understand how to overcome those judgments. So again, it's very important to be aware of our own personal bias, and also help the supervisee to be more aware of their personal bias. And then promote practices to the multicultural competencies, and that's part of the ethical codes, is to have multicultural perspectives and competency as so it's almost like the supervision process will bring that in and kind of also model in that way. We talk about open to feedback, learning new ideas, meaning, yes, we have been doing things the same way. Doesn't mean we cannot try a little bit new things, or more interactive counseling process, role plays, or different new ideas. So that would be good, just even talk about it. It may not be appropriate, but again, I think it's good to even learn why is it not appropriate. And then, having discussion about those, how to help the supervisees be more aware and understanding how to counsel different populations. I know like a very senior therapist that he's not comfortable to counsel LGBTQ clients because of religious. And I think that has been some cases from ACA to kind of address that issue. But as a counselor, we still need to be open-minded and understand how to help clients and how to increase our competency. So again, those are very important topics to help supervisees. And then need to understand historical trauma, racial trauma, discrimination, gender inequality. And again, those are very sensitive topics, but we need to continue to bring the awareness to the supervision session so that we can help our supervisees grow. And then also we need to understand re-traumatization, some of the re-traumatization practices, because we, again, the goal is to help them kind of understand and heal from the trauma, not to force them or not giving choices to the point that they re-traumatize again in this supervision process. So for example, we are not going to force them to say, hey, talk about, what's going on, your personal life or different things if they are not comfortable sharing. Again, there are some professional boundaries we need to, as a supervisor, understand that. So in conclusion, just the strength. And as you know, I think this is required to have for all the supervisors, hopefully, to really practice this. And that's why Amanda and I are very big on promoting trauma-informed supervision, because this is so important. Because it's a strengths-based, ethical, multicultural practice that prioritizes self-care and wellness for not only supervisees, but it's also impact clients and supervisors. Because when we have a good relationship or we feel good, we help other people feel good, we also feel achieved. So again, when we teach, even though it's our boundaries, again, that's still helping them grow. So again, that's very important to be aware of. And then some research continue to say, the trauma-informed supervision will increase the report and the relationship between the supervisees and client as well. And we have been repeating that. I think also can be incorporated to many models of supervision. I think this is so important because there are different models of supervision, but you can add this as on top of the supervision model that you currently are adopting. Okay, so I think that's our presentation.
Yeah, so I just we both want to stop and take a minute and, if you guys have any questions, I know you've been collecting that for us, so we have just a few minutes for that.
I have a quick question for one or both of you. I'm only in my first year of the master's program, but I know that our supervisors can't act as when I get to that point, they can't act as our counselors in case we get re-traumatized or something, but it is sufficient for our supervisor to be our consultant, correct? Is that okay? Yeah,
that's absolutely fine. Yeah, they can't do you're right. They can't be your therapist, but like I said, it's more, we're going to have different roles. It's just doing them appropriately.
Yep. So for example, a lot of individual traumatized detail you want to share with individual therapist versus how that is impacting your clinical skills, or how do you deal with transference, countertransference. Those are the one that you can talk to your supervisor about. So again, there are different ways of helping you as a counselor, different roles like what we talk about. Is that helpful?
Yes, thank you very much.
Awesome. Anybody else?
Do we have mostly students here or clinicians?
See some of this stuff popping up in the chat box. Let me open it.
Supervisor. Okay. What do you think about this training? Do you feel like it makes sense?
Yes, definitely. I appreciate it. And I appreciated the question too about that Joey asked about the counseling, the different roles, because it does come up in supervision when, and I'll just share this real quick. I live in Louisiana, and I was teaching practicum when Hurricane Katrina hit. And I was displaced Although, you know, thankfully I still had a house, but I was dealing with a lot of practicum students who were also
Wow.
displaced, affected by that trauma. And also they were dealing with clients who had been affected because a lot of the students from New Orleans came to where they were practicing. So you had 3 different levels of a very fresh trauma situation. So we had to be very careful about kind of monitoring those roles. So thank you for this. It's been very helpful.
Thanks.
Yeah.
I
You
see
have
a lot
a
of
good
people-
point.
Yeah, good point with that. Yeah. I see people are clinicians and supervisors. Yeah. So we have kind of a mix here. That's awesome, of people that are in this. I assumed everyone was somewhere in their process of becoming a clinician at least.
And June, you are right. It's very difficult to deal with different layers of trauma, especially when the trauma is fresh. It's called acute distress disorder. So it's not even like a PTSD yet, right? So you need to be, so you are currently in that distress. Okay, so again, that's very hard trying to do all work and support your student when you're going through acute distress. So I hope you got enough resource, enough referrals, or, you know, you probably need to give referrals out for more resources for your student, for yourself, and for your clients. But I'm glad that you're okay now.
Awesome. Good thoughts, guys. Anybody, any other questions? Or thoughts? You can comment. I know we don't have very much time, and I know you guys probably have other stuff. We're only got a couple more minutes, but you know, if you have other things, yeah, someone said I have taught practicum. This sometimes hard to address when students and interns are triggered by trauma and they are not. Yes, absolutely. That's a tricky one. That would be a further one. You're right. We could go on for hours about this, but you're absolutely right. And we realize with this training, and this is kind of a general overview. So this is definitely not saying like, here you go, just do it. It's giving you like some food for thought in your process to learn more. But you're right. It gets much more tricky, and sometimes they're not receptive. That is actually accurate. Yeah, I know we don't
that's
have.
why it require more skills. And I think, you know, it's very important to see consultation and like, you know, reach out to therapists like Amanda has a lot of experience about supervision and different people. We want to gently help them, but get some
even
support.
as supervisors being like, hey, I need some peer support myself, because we all do. No matter how experienced you are, we're like, I'm having a problem with this person, this student. How do I help? Because we ask other people and get their advice in there, and we're kind of in that way we're modeling that for our supervisees, because we do it as well. And it's always good to see someone who models that we're always learning. I mean, until we die, I always say you're still learning.
I love it.
That's just, you know, a way. I want to leave you with one quick thought, a quote. Every single one of us works alongside human beings who is intricately exposed to someone else's safety seeking and our own. So thank you for your participation. We enjoyed being with y'all.
Thank you so much. We have enjoyed being your presenters, and